Imagine waking up,
Yeah.
right? Every single morning. And the moment you open your eyes, your body feels like it's just stepping into this immediate, massive adrenaline rush.
Right, like full panic mode.
Exactly. Full fight or flight. Your heart is pounding and your brain feels like you're, I don't know, trying to swim through wet cement.
Yeah.
And then you try to get out of bed.
Yeah.
And just bumping your shoulder against the door frame causes your joint to physically slip out of its socket.
Oh, man.
But here's the real kicker. You look in the mirror, you walk out your front door, and to everyone else around you, you could look perfectly, radiantly healthy.
It is the ultimate invisible reality, honestly. And it completely upends how our medical framework operates.
Right.
Because, we are conditioned to look for a cast or a cough or a tumor.
Some outward sign.
Exactly, some localized sign of structural failure. So when the structural failure is microscopic and systemic, the entire diagnostic apparatus basically short circuits.
Okay, let's unpack this, because today we're doing a deep dive into a really massive, incredibly detailed medical text called Disjointed. It's edited by Diana Joven and written by this huge coalition of specialists. And we are looking at hypermobile Ehlers-Danlos Syndrome, or hEDS.
And hypermobility spectrum disorders, too.
Right, but we're looking at it through a very specific lens today, which is the lived female experience.
Which is so important.
It really is. We are tracking how this condition collides with puberty, pregnancy, motherhood, and menopause. And crucially, we're looking at what happens when a body fighting a multisystemic war is forced to navigate a society and a medical system that demands traditional role performance.
And cruelly dismisses the illness while doing it.
Yes, exactly.
To understand the sheer scale of that dismissal, we really have to look at the underlying biology of what hEDS actually is.
Okay, lay it out for us.
So connective tissue is the scaffolding of the entire human body. In hEDS, the genetic instructions for making that connective tissue are altered. The result is tissue that is just overly stretchy, fragile, and lax.
Okay.
And because connective tissue is in your joints, your skin, your blood vessels, your digestive tract, your organs, the faulty scaffolding is literally everywhere.
See, the defining characteristic that most people know is generalized joint hypermobility, right? Like measured by the Bacon scale.
Yeah, being double jointed, people call it.
Right. But the source text makes it painfully clear that labeling hEDS as just bendy joints.
Yeah.
It's a really dangerous oversimplification.
Oh, absolutely.
It's like trying to build a skyscraper with rubber beams, but the city inspectors only check the paint job.
That's a great way to put it.
They see the joints moving too far and completely ignore the fact that the vascular system and the gut are made of the exact same rubbery material.
Yeah. And that structural reality collides with a pretty staggering demographic fact. There is a 3-to-1 gender divide here. Yeah, this disorder predominantly affects women. And, historically, any complex, multisystemic, invisible illness that predominantly affects females.
It's exactly the profile of a condition the medical establishment overlooks.
Exactly. It just gets ignored.
There's an analogy from the text about impaired proprioception that I thought perfectly captures the psychological toll of this.
Oh, the VR one.
Yes. A patient described lacking proprioception, not knowing where your body is in space, as being like a virtual reality video game where there is no floor.
That is just terrifying to think about.
Right. You know the floor should be there, but your body is constantly misreporting its location in space. Think about how much of our daily 9-to-5 lives, our school schedules, our expectations of parents, relies on the assumption of a predictable body.
Right, that your body will just do what it did yesterday.
Exactly. When you strip that predictability away, society has absolutely no safety net for you.
You lose the fundamental trust in your own physical vessel. And because the symptoms are so varied, well, like a dislocated shoulder on Monday, extreme brain fog on Tuesday, maybe gastroparesis on Wednesday.
Wow. So it's all over the place.
Right. It creates a fractured clinical picture. And it sets the stage for doctors, employers, and even spouses to completely misinterpret what they're looking at.
Let's look at the numbers on that misinterpretation, because the diagnostic delay in the text is just enraging.
It really is.
Men with hEDS wait an average of 4 years for a correct diagnosis.
Which is already a long time.
It is. But women wait an average of 16 years.
16 years.
16 years. That is a 16-year gap of just wandering in the medical wilderness. I have to assume that gap isn't just bad luck.
No, not at all. It is a structural failure of how we practice medicine, and it's heavily compounded by gender bias.
How so?
Well, modern medicine is highly siloed. So a patient walks in with 30 different, seemingly unrelated symptoms across multiple systems, right?
Right.
The gastroenterologist runs a scope, the neurologist runs an MRI, the orthopedist does an X-ray, and those localized tests all come back normal.
Because they're looking for standard damage.
Exactly. Standard imaging doesn't detect lax collagen fibers holding the organs together. So when the objective data doesn't match the subjective complaints, the physician defaults to the psychiatric red herring.
Ah. Which brings us to the autonomic nervous system, because this is where the psychiatric misdiagnosis really takes root, doesn't it?
Oh, heavily.
These patients are told they are having panic attacks, but there is an actual biological, biomechanical reason their heart is racing at like 130 beats per minute while they're just sitting at a desk.
Yes, what's fascinating here is dysautonomia, specifically POTS, or postural orthostatic tachycardia syndrome, which is a really frequent comorbidity.
Okay, break that down for us.
So the autonomic nervous system manages the background processes: heart rate, blood pressure, digestion. In hEDS, the veins in the lower half of the body are overly stretchy.
Because of the faulty collagen.
Right. So when the patient stands or sits up, gravity pulls the blood down, and those lax veins can't constrict properly to push it back up. So the blood just pools.
Wow, so the brain is essentially getting starved of oxygen.
Precisely. The brain senses hypoperfusion, which is a lack of blood flow.
Okay.
And to compensate, it triggers the sympathetic nervous system. It dumps massive amounts of norepinephrine and epinephrine into the bloodstream.
Basically adrenaline.
Exactly. To force the heart to beat faster and harder, trying to manually pump that pooled blood back up to the brain.
So the patient is literally just sitting still, but their internal biochemistry is responding as if they are outrunning a predator.
Yes. They're experiencing tachycardia, sweating, tremors, and impending doom.
And to a doctor who isn't screening for orthostatic intolerance.
That looks identical to an anxiety disorder.
Oh my gosh. And they are handed an SSRI and told to practice mindfulness.
Yeah. But breathing exercises cannot fix a structural hypovolemia problem in stretchy veins.
No amount of deep breathing is going to tighten a physical vein.
Exactly.
And the misdiagnosis goes way beyond anxiety, too. The text explicitly maps out a deep neurological overlap between hEDS and AuDHD, so autism and ADHD.
Yes, it's very prevalent.
Autism is actually listed as part of the pentad syndromes associated with hEDS. I really need you to explain the why here. How does a connective tissue disorder relate to neurodivergence?
It's a great question.
Are we talking about structural issues in the brain itself?
Well, what's fascinating here is that the medical community is really just beginning to map the biomechanical underpinnings of this overlap. But there are a few leading theories discussed in the broader literature.
Okay.
First, connective tissue isn't just in your joints. It makes up the extracellular matrix in the brain.
Wait, really? In the brain?
Yeah, and if that matrix is faulty, it could impact neuronal migration and connectivity during fetal brain development.
Oh, wow.
And second, we have to look at the chronic autonomic stress we just talked about.
The adrenaline.
Right. If a developing brain is constantly marinating in adrenaline and cortisol because the cardiovascular system can't regulate blood pressure,
That has to alter things.
it alters neurological development and sensory processing.
So if your body's hardware is constantly misreporting its location in space, going back to that lack of a VR floor, the brain's software has to run on overdrive just to keep you upright.
Exactly.
It completely fries your sensory processing bandwidth. So no wonder it mimics or co-occurs with autism and ADHD. The brain is structurally and chemically overwhelmed.
It really is. And when you ignore that biological reality and you tell a young girl in agonizing pain that her physical reality is just psychological weakness or attention seeking,
The trauma compounds.
it compounds massively. The text actually details adult patients accused of conversion disorder, where doctors claim mental stress is manifesting as physical joint dislocations.
That's insane. They're physically dislocating, and they're told it's just stress.
Yes, they are accused of malingering,
Yeah.
of faking it.
It gets darker, honestly, because parents of children with hEDS are frequently accused of Munchausen by proxy.
Yes. Medical child abuse.
Imagine your child as joints are subluxating, they are dizzy, they're exhausted. You take them to a specialist begging for help.
And instead of running a bait and score or an autonomic tilt table test,
The doctor calls Child Protective Services because they think you are medicalizing normal childhood bumps and bruises for attention. It is the ultimate betrayal by the safety net.
it happens because psychologically it is easier for a siloed medical system to label a complex, multisystemic patient as factitious than it is to admit the system lacks the framework to diagnose them.
Right. It's easier to blame the patient than admit ignorance.
Exactly.
But the gaslighting doesn't stop at the clinic door. The social expectation to perform is brutal. There's this anecdote in the text about a mother facing a spouse who fundamentally refused to believe the familial HEDS diagnosis.
Oh, that story is heartbreaking.
He belittled the medical treatments she and their daughters needed, demanding traditional neurotypical functioning from them.
Right.
And it ultimately resulted in their divorce. Just the emotional toll of fighting a multi-systemic war inside your body, only to have your partner look at you and say you just need to eat healthier and exercise, is devastating.
And it is rooted in a societal demand for predictability.
Yeah.
And telling an HEDS patient to just push through it or exercise more is actively dangerous advice.
Because their bodies can't handle it.
Right. Traditional high-impact exercise or aggressive physical therapy regimens designed for normal collagen will physically tear their tissues and permanently damage their joints.
So if the social and medical baseline is already this hostile, what happens when you introduce natural biological volatility into the mix?
The hormonal shifts.
Let's look at the female life cycle, because the impact of hormones on this faulty connective tissue is just mind-blowing. The text states that more than half of female patients report puberty as the trigger point, where their symptoms either began or became significantly disabling.
To understand why puberty is the catalyst, we really have to look at the endocrine system's direct physiological effect on ligament laxity.
Okay, so how do hormones change things?
Even in healthy bodies, female sex hormones, particularly progesterone and estrogen, change the stretchiness of connective tissue. As the reproductive machinery turns on during puberty, the hormonal fluctuations begin acting on collagen that is already genetically compromised.
Let's talk about the luteal phase of the menstrual cycle then. When progesterone spikes in that second half of the cycle, what is actually happening mechanically to HEDS collagen?
Well, progesterone's biological mandate is to relax smooth muscles and ligaments in preparation for a potential pregnancy.
Right, making room.
It decreases collagen synthesis and alters the cross-linking of the fibers. Now, in a typical body, this causes slight manageable flexibility.
But in HEDS?
In an HEDS body, that extra progesterone spike is catastrophic. It makes the ligaments so compliant that they can no longer maintain joint apposition.
So the joints literally can't stay together?
Yes. Women experience a severe cyclical increase in joint instability, partial dislocations, and structural pain tied directly to their hormonal fluctuations.
Every single month.
Every single month.
But the chaos isn't limited to the musculoskeletal system. We have to bring in mast cell activation syndrome, or MCS, which is another one of the pentad syndromes traveling with HEDS.
This is a huge piece of the puzzle.
Right. Mast cells are the immune system's first responders, releasing histamine to fight off threats. But in this population, they are incredibly unstable. Why do these immune cells suddenly go haywire at puberty?
Simply put, because mast cells have receptors for estrogen and progesterone on their surfaces.
Wow. So the mast cells are the smoke detectors, but the hormones are basically hacking the sensitivity dial.
That is an excellent way to conceptualize it, yeah.
Okay.
As hormone levels churn and spike during puberty, and then cyclically every month, they bind to those mast cell receptors.
And what happens?
This triggers degranulation. The cells basically explode, releasing massive cascades of inflammatory mediators into the tissues.
Just flooding the body with inflammation.
Exactly. This is why girls with HEDS suddenly develop severe, unexplained allergies, chemical sensitivities, strange rashes, and systemic inflammation the absolute moment they hit puberty.
And that inflammation really zeroes in on the pelvic region.
It does.
The text highlights incredibly high rates of endometriosis and polycystic ovary syndrome, or PCOS, in this population.
Right.
It makes structural sense when you think about it. Uterine fibroids contain abnormal collagen patterns. But how does PCOS feed into the mast cell issue?
Well, PCOS creates a state of systemic chronic inflammation and hormonal imbalance.
Okay.
That chronic inflammation constantly irritates the mast cells, and in turn, the hyperactive mast cells release mediators that further inflame the ovarian tissue. It is a vicious, self-sustaining biochemical loop.
Which explains a symptom that gynecologists apparently routinely brush off, which is dyspareunia, or severe pain during intercourse.
Unfortunately, yes.
If a woman is dealing with HEDS and MCS, her pelvic floor is structurally weak. Right. The fragile veins are pooling with blood because the connective tissue walls are too lax to pump it out. Pelvic congestion syndrome.
Exactly.
And the pelvic floor muscles are spasming to hold the organs in place. And on top of that, the tissues are saturated with degranulating mast cells.
The entire genitourinary area is inflamed at a cellular level.
Wow.
So when she complains of severe pelvic pain, it is a biomechanical and biochemical crisis. It is not a psychological aversion, and it is not anxiety.
No. Her pelvic floor is literally bathed in histamine.
Right.
This cycle continues for decades until menopause. And menopause doesn't cure the hEDS, but the mechanical instability changes, right? As estrogen drops and the reproductive machinery slows down, the joints actually tend to stiffen up.
Yes. The structural nature of the tissue changes as it ages and loses that cyclical hormonal lubrication.
Okay, so that sounds like a good thing. Less dislocations.
It sounds like it, but the subluxations may decrease. But the accumulated joint damage from decades of instability often leads to severe, early-onset osteoarthritis.
Oh, I see. So it just trades one type of pain for another.
Pretty much.
So if the regular monthly hormonal cycle causes this much systemic chaos, joint slipping, mast cells exploding, blood pooling, what on earth happens when a hypermobile body goes through the ultimate hormonal and physical stress test? Pregnancy.
If we connect this to the bigger picture, pregnancy in an hEDS patient is a high-risk biomechanical event, and it requires intense proactive management starting long before conception.
The text emphasizes preconception genetic counseling because hEDS is autosomal dominant.
Right, meaning a 50% chance of passing it on to the child.
But the physical prep is intense too. They require baseline echocardiograms. Why are we looking at the heart before pregnancy?
Well, connective tissue forms the valves and the structural walls of the heart. While vascular EDS is the subtype known for catastrophic arterial ruptures, patients with hEDS still exhibit high rates of mild aortic root dilation or mitral valve prolapse.
Gotcha.
And pregnancy dramatically increases maternal blood volume and cardiac output. The heart has to pump much harder against a much larger fluid volume.
That makes sense.
Right, so a baseline echocardiogram ensures the cardiac structures can handle that massive increase in hemodynamic load without failing.
Once the pregnancy begins, the physical toll is just wild. We just talked about progesterone. But in pregnancy, the body introduces relaxin.
Yes, a hormone specifically designed to loosen the pelvic ligaments for childbirth.
But for a hypermobile woman, her joints are already loose, so now they're stretching way past the point of stability.
Way past.
The sacroiliac joints at the base of the spine slip in and out of place constantly. The text notes that these women frequently require heavy-duty SI belts to physically hold their pelvis together.
Sometimes as early as the first trimester.
That is just mind-blowing.
The structural challenge is immense. However, there is a fascinating paradox regarding the autonomic nervous system during this time.
Here's where it gets really interesting.
Yeah. We discussed POTS earlier, the dysautonomia caused by blood pooling in lax veins. You would assume the massive physical strain of carrying a child would exacerbate this, right?
Right. You'd think it would be a nightmare.
But for some hEDS patients, their POTS symptoms actually drastically improve during the second and third trimesters.
Wait, really? Because the pregnancy itself fixes the hypovolemia?
Exactly. Maternal blood plasma volume increases by up to 50% during pregnancy to support the placenta.
Oh, wow.
This extra volume acts as an organic internal treatment for POTS. It physically fills up those stretchy veins, increasing venous return to the heart and brain.
Which temporarily stabilizes the autonomic nervous system.
Yes, it's pretty incredible.
It's a rare moment of relief, even if it disappears the moment the blood volume normalizes postpartum.
Right.
But getting to postpartum requires surviving labor and delivery, which is fraught with structural risks.
Heavily fraught.
The text outlines premature rupture of membranes because the amniotic sac is made of collagen, right?
Yes.
So if the collagen is faulty, the water breaks too early.
Exactly.
Then there's the incompetent cervix, where the cervical tissue simply cannot hold the weight of the fetus and begins to dilate prematurely.
And the laxity of the tissue also leads to rapid, sometimes precipitous labor. The tissue just provides very little resistance.
Wow.
Furthermore, if the fetus has inherited the hEDS mutation, their hypermobility allows them to easily contort into breech or transverse positions late in the third trimester.
Which complicates the delivery path.
Very much so.
And the anesthesia risks. I was shocked reading this part. The anesthesiologist typically instructs the mother to curl her spine forward tightly to open the vertebrae for the epidural needle.
Standard procedure, yeah.
But the text warns that because of her hypermobility, bending that far forward under stress can literally dislocate her hip on the delivery table.
Which underscores exactly why an EDS-aware medical team is critical. Standard obstetric protocols assume normal tissue integrity.
I have to ask the obvious question here, though.
Sure.
If the mother's pelvis is super loose and the tissue offers no resistance, wouldn't pushing a baby out actually be easier?
It is a double-edged sword. Obstetric literature does note that women with hypermobility are sometimes less likely to suffer severe anal sphincter tears during delivery.
Okay, because of the stretchiness.
Precisely because the perineal tissues stretch so easily to accommodate the infant. But that extreme compliance comes at a catastrophic cost during the postpartum period.
Because the rubber band doesn't snap back.
Exactly. The lack of tissue recoil means that once the infant is delivered, the ligaments supporting the uterus, bladder, and rectum remain stretched out.
Oh, no.
This leads to a massive incidence of pelvic organ prolapse, where the pelvic organs physically descend into the vaginal wall.
That sounds horrific.
It is. It requires highly specialized pelvic floor physical therapy that focuses on strengthening the surrounding musculature without overstretching the ligaments, and frequently requires surgical intervention.
And while navigating her own structural collapse, she is trying to care for a newborn.
Right.
The text notes mothers subluxating their ribs or dislocating their shoulders just from the mechanical strain of holding and nursing an infant.
Yeah, just picking up the baby can cause a dislocation.
And if the baby inherited hEDS, they frequently present with hidden tongue ties.
Yes, tethered oral tissue caused by abnormal collagen formation.
Making it incredibly difficult for the baby to latch. So it is an onslaught of physical challenges, colliding with the societal expectation that new mothers should be glowing, multitasking, capable superwomen.
Absolutely. Navigating motherhood with the body that the occupational therapist in the text describes as a rust bucket requires a total paradigm shift.
A rust bucket? That's such a striking term.
It is. You cannot hold yourself to the standards of a neurotypical, physically robust society when you are operating a fundamentally different physiological machine.
Reading this text, it becomes glaringly obvious that trying to perform normalcy is literally destroying these patients.
Completely.
So how do they exit these toxic dynamics? Because the psychology chapter is brilliant. It makes it clear that the first step in treating hEDS isn't a brace or a medication.
Right.
It is a profound psychological shift.
Yes. Patients must stop measuring their self-worth against the expectations of healthy people. Society demands that they fulfill traditional roles. You know, the employee who never calls in sick, the mother who attends every PTO meeting, the tireless spouse.
Yeah.
When your body is fighting a multi-systemic war every day, striving for that specific version of normal guarantees a catastrophic crash.
So how does therapy address that?
Therapy for hEDS isn't about cognitive behavioral strategies to ignore the pain. It's about grieving the able-bodied life they thought they would have.
Wow.
And rebuilding an identity based on their actual physiological limits.
The text introduces the concept of the reliable worker or reliable partner, which I loved.
Yeah, it's a great concept.
Right. When your joints dislocate randomly, or a dysautonomia flare wipes your cognitive function, you are physically unpredictable. And society equates physical unpredictability with being unreliable.
Which makes patients feel like immense burdens.
Right. But the therapist points out that you can separate your reliability from your physical output.
Exactly.
You might not be able to guarantee you can walk on Tuesday, but you can be reliable through impeccable communication, contingency planning, and delegating.
Reclaiming agency over how you interact with the world also requires changing the narrative around assistive tools. There is immense internalized and external stigma regarding mobility aids. Wheelchairs, finger splints, SI belts.
People treat wheelchairs like giving up. But if you have to cross a desert, taking a car isn't giving up. It's just smart resource management.
That is exactly the point the occupational therapists make. They argue that a mobility aid is a tool of freedom, not a chain.
Okay, how so?
If walking through the grocery store consumes 100% of your daily energy envelope and triggers a 3-day pain flare, you are disabled by your environment.
Right.
If you use a wheelchair for that errand, you preserve that energy. You can come home, cook dinner, and engage with your family. The wheelchair didn't make you more disabled. It facilitated your participation in life.
That's a huge mindset shift.
It is.
So, what does this all mean for the patient practically? It means building a microenvironment that actually supports them. You fire the gaslighting doctors.
Yes.
You build a collaborative health team. physical therapists who understand isometric strengthening without stretching, dysautonomia specialists, allergists for the mast cells, and you set impenetrable boundaries with the doubters.
The psychological strategy of the preformed answer is vital here.
Okay, tell us about that.
When a family member or an employer questions the validity of your illness, you do not expend your finite energy trying to convince them. You deploy a rehearsed clinical boundary.
You just shut it down.
Yes, you learn when to walk away because you cannot afford to spend your limited energetic currency on people committed to misunderstanding you.
You stop fighting the illness to please a demanding society, and you start working with your body.
Precisely.
It's about pacing and accepting the absolute necessity of rest. The no pain, no gain mentality is a death sentence for hEDS tissues. Pushing through the pain only causes a cascade of downstream structural damage.
This raises an important question, though, perhaps the central paradox of living with hEDS. How do you achieve functionality?
Right.
The answer is that accepting the disability is the key to functionality.
Wait, accepting it is the key.
Yes. By adopting joint protection strategies, honoring the energy envelope, and unapologetically utilizing accommodations like modified work schedules or IEPs in schools, the patient achieves a much higher quality of life.
Oh, I see. Functionality comes from honoring the structural limits, not ignoring them.
Exactly.
Wow. We have covered an immense amount of ground today. Hypermobile Ehlers-Danlos Syndrome is a profound, multi-systemic condition that compromises the structural integrity of the entire body.
It really does.
And the female life cycle turns puberty, the menstrual cycle, and pregnancy into extreme physiological stress tests due to the interaction between hormones, fragile connective tissue, and hyperactive mast cells.
Yes.
But the most vital takeaway from Disjointed is that the greatest harm often comes from the toxic expectations of a society and a medical system that demand normal performance from a body fighting a massive, invisible battle.
The diagnostic delays, the psychiatric misdiagnoses, the accusations of factitious disorders, these are systemic failures of scientific curiosity and basic empathy.
Think about how much of our own daily lives rely on our bodies just, showing up. Whether you have hEDS, know someone who does, or just interact with humans, we have to radically rethink how we judge chronic, invisible illnesses. We must extend grace when bodies cannot meet traditional expectations, because you never know if the person standing next to you is navigating a virtual reality game with no floor.
Very well said. And as we close, there is one final, incredibly provocative concept drawn from the implications in the text.
Oh, let's hear it.
The experts repeatedly refer to hEDS patients as the canaries in the coal mine.
Why?
Because their connective tissue is overly porous. They lack the tight cellular junctions that normally protect the body's internal environment.
Meaning they are highly susceptible to environmental toxins.
Exactly.
Microplastics, herbicides, organic solvents, and molds slip right past their compromised barriers, constantly triggering their mast cells.
If the hEDS body is essentially a porous sponge reacting violently to the modern environment, and we know their mast cells are deeply sensitive to hormonal disruption.
Oh, I see where you're going with this. What does that mean for the general population?
Exactly. Could the exponentially rising levels of endocrine-disrupting chemicals and microplastics in our food and water be quietly degrading the baseline health of an entire generation's connective tissue?
Are these canaries, with their invisible, multi-systemic battles, warning us about an environmental saturation point? A tipping point that won't just affect those with a genetic predisposition, but will eventually come for us all. Something to think about.